Hey guys, Woodruff here. So now let's talk about asystole. So this rhythm, probably out of all the rhythms, hopefully you should be able to discern what this one is because it's the only one that's a flat line. There is no electrical activity, there is no rate, there is nothing to measure, there's nothing to look at. It is just a flat line. Now you might say, but oh, this one's kind of wavy. It's really not. So like there is like it is a flat line, like there's no like fibrillatory or other activity. So what we're going to do for asystole is we are going to, sorry, I'm trying to find my mouse here. I don't know why this is so hard to find. There it is. There is no real treatment to do for this except to try to restore circulation. Now you might say like, because you see it all the time in the shows, is that they shock this rhythm. You cannot shock a flat line. You cannot shock asystole. So if someone has zero electrical activity, what we do is we still attach that. We get the crash cart, we attach them, but we're not trying to shock them. The priority is going to be CPR, and then giving medications like epinephrine in order to restore circulation. We're going to keep doing this. Now, if at some point they regain some fibrillatory waves, then we can maybe shock that. But this rhythm on itself is not shockable. You cannot shock a flat line. So the confusion here is that most people think shock is like a restart where I'm kind of like I'm jumping a battery. And I can remember in real life, I can shock, I can jumpstart. I'm not a car expert, by the way. So if I'm wrong about this, just, pity me and, play along. But from my knowledge, very few knowledge of cars, is that like if my battery is completely gone, completely dead, there's nothing to it. Like it's not something that can really be restarted. If I still have some bit of electricity or something in that battery, then we can shock it. But if there's no electricity, it's dead, it's gone. There's nothing that can be restarted. And it's the same in the heart. And so if there's no electrical activity, there's nothing to shock. I have to have something to shock to try to convert it or restart it. But if there's nothing, if it's just battery is gone, then that there's nothing that I can do there. So again, pretty much priority is start CPR, and then hope that the CPR and the medications will restore this. Now, let's do a case study that's over ventricular. So we have a patient, Rachel, and she is a 59-year-old female with a history of hypothyroid, GERD, and hypertension. She was at work and she started feeling lightheaded and dizzy. She's having trouble catching her breath, and her coworkers help her sit down and call 911. When the EMS arrives, they find her in this rhythm. So let's look at this. So we know it's going to probably be something ventricular, but let's just in case. So I don't see any P waves. I see a bunch of QRSs. Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. So she's got a rate of like 240 about. So about a rate of 240. And then it's fairly regular. It's not that irregular. So it's fairly regular. So I've got a fat rhythm that's fairly regular, that's fast. So I can actually count the rate. So if I had to choose between it's not asystole because it's not a flat line. If I had to choose between a VFib or VTAC, I'm going to say VTAC because I can actually count the rates. Like it is semi-discernible. So I've got a VTAC going on here. And then I remember my priorities for VTAC. So the first thing I want to do is, it sounds like, like she's talking and stuff like that, but I would still want to check a pulse. And then if she had a pulse, then I would be doing things, checking her blood pressure, checking her oxygenation, applying oxygen, getting a 12-lead EKG to confirm the rhythm, etc. And then we want to convert her as soon as possible. And we may either medically convert her with medications, or we may, excuse me, have to cardiovert her. So that going with this, again, this is a little bit of a different VTAC, but still same thing. Priority is the oxygen, patent airway. We're looking for perfusion, seeing if she's stable or not. But regardless, she's going to need some sort of treatment. If there's a pulse present, medications to convert or cardiovert. But again, I didn't bring this up, but if there's no pulse, then we would start CPR, defibrillate as soon as possible, and then maybe epinephrine, other medications to medically convert her. So the procedures we would need are the defibrillation if there's no pulse, cardioversion if there's a pulse present, and if this is a chronic problem, she may need an ICD placed, or she might need to get some electrophysiology studies done. So that's the end of ventricular rhythms. The next thing we're going to talk about is premature ventricular contractions and what those look like. I'll see you for the next one.